We've been told to watch out for what we get in our diet. A lot of health professionals will tell us that a lot of issues can come about if we have too much or too little of them in our diet. But at the same time, they tell us that we have to go and make sure that we drink them in all of our fluids so we stay hydrated after we work out. Which takes us to understanding the importance of electrolytes. What issues might come about from electrolytes? How are salts and electrolytes important in terms of our normal physiological functions? And how can they impact our physiology? Well, let's talk about that.
Warning. The following presentation contains information that might contradict what you have previously heard, or believed to be true, about how the human body works, and contains material that is not suitable for closed-minded individuals. Enjoy!
So when we start talking about and looking at electrolytes within the body, what are we talking about? We're talking about things like potassium, magnesium, sodium, calcium, phosphate, and chloride, just to name a few. All of them can come about and be seen in normal physiological functions and physiological tests that we might see with our healthcare professionals. But what do they do for us? What is the importance of those types of electrolytes? All those electrolytes will have an impact in our overall level of hydration, the overall level of water balance we have in our body, and all of them will impact our normal physiological functions. A lot of them will have impacts on membrane potentials of excitable tissues that will impact the ability for the heart to function correctly, for the muscles to function correctly, for the neurons within the brain and the neurons within the nerves of the body to function correctly, to allow for bone growth and bone healing following injury, or simply allow for the bones to grow in response to all of the stresses that we place on them throughout all the things we do on a regular basis. But at the same time, they're going to be responsible for causing actions within the hormones, within the endocrines, within the endocrine system, within the endocrine tissues, allowing for normal hormone production and normal hormone release. One such electrolyte that we have to worry about, one such salt we have to worry about is calcium. Now, calcium usually gets lumped into bone and bone health, even though that's only one spot that we'll see calcium within the body. Calcium is essential for normal membrane functions, for normal muscle functions, and is going to be involved with all excretions from every cell in the body, whether it's the neurons secreting a neurotransmitter, or the endocrine tissues releasing endocrines, or just cells releasing chemicals outside of the cells. We'll see calcium involved in all protein contractions, all muscle contractions throughout the body, whether that be the skeletal muscles allowing us to move, the cardiac muscle allowing for the heart to beat, or the smooth muscles of the gastrointestinal tract or the blood vessels to regulate the diameters to move fluids and move stuff around the body. A lot of calcium is going to be maintained based off of two key hormones. Those two key hormones are parathyroid hormone and calcitonin, as well as vitamin D. Normal calcium levels will be between 8.8 and 10.7 milligrams per deciliter. Anything above this range is hyper. Anything below this range is hypo. We'll see that same designation when we look at all of the other electrolytes here as we work through the discussion. So what happens if we have too much calcium? Hypercalcemia. Hypercalcemia is going to have distinct causes to them. We can have parathyroid regulated issues, such as having inappropriate parathyroid levels or inappropriate responses to parathyroid hormone. We could have familial issues and genetic issues that can lead to a loss of the function of the calcium sensing receptors within the genes. And we could have issues in terms of medication impacting parathyroid hormone actions, such as lithium, which is going to alter the way in which calcium is being metabolized due to changes in parathyroid functions. We could also have non-parathyroid hormone related issues that come about from medication issues, such as loop diuretics, calcium reabsorption diuretics, excessive calcium carbonate consumption, long-term use of retinoic acid, hypercalcemia malignancies that come about due to excessive production of parathyroid-related hormones, vitamin D toxicity, hyperthyroidism leading to an insufficient ability for the adrenals to regulate cation loss at the kidneys, as well as changes in calcium metabolism at the bones. Immobilization and disuse leading to an imbalance in between loading and unloading of the bones, leading to increase in bone breakdown, leading to an increase in calcium being released from the calcium stores within the bones. So what are some of the issues that we might see in terms of hypercalcemia? Well, we'll see things like weakness and nausea. We'll see things like cramping. We'll see bone weakness and possible increase in risk for fractures. We could see osteopenic changes within the bones themselves. We can see altered levels of brain functions, altered levels of neuron functions. We could possibly see altered level of consciousness and possible headaches. But what about the hypo condition? What about having too little calcium? Too little calcium, once again, is going to be related to parathyroid hormones, where we're going to start seeing things like parathyroid deficiencies coming about post-surgically, coming about due to an autoimmune disease issues that will somehow obliterate the parathyroidism, the parathyroid. We can see abnormal parathyroid gland development. We could see distinct congenital issues that can come about. We could see diseases of the parathyroid gland that can all lead to parathyroid deficiencies. We could also see hypocalcemia coming about from high parathyroid levels, particularly when we have a vitamin D deficiency issues or when we have chronic kidney disease issues. We could see a pseudohypothyroidism, which is going to come about due to a genetic disorder which causes resistance to the action of parathyroid hormone. We could also see other issues coming about, particularly in terms of acidosis and alkalosis, leading to calcium binding to albumin based off of changes in serum pH. We could see issues in terms of acute pancreatitis causing issues in terms of the ability for calcium to be transported throughout the blood. We could see issues coming about due to sepsis and illness and trauma causing shifts in calcium and in calcitrol issues. We could see the associated calcium and magnesium issues, where changes in calcium leads to changes in magnesium, and changes in magnesium lead to changes in calcium due to the parathyroid issues that can cause changes in bone metabolism. We could see issues in terms of drugs coming into play, which is going to lead to increase in osteoclastic activity that is typically concomitant to a vitamin D deficiency. We could also see a hypocalcemia issue coming about due to blood transfusion. We may also see hypocalcemia in terms of dietary issues, particularly dietary restriction issues. Dietary restriction issues that can come about, particularly for pregnant females that do not get enough calcium in the diet or somehow have vitamin D deficiencies. So what issues might come about because of hypocalcemia? Well, we could see things like weakness and nausea. We could see cramping. We could see bone pain and bone weakness. We could see flexion contractures, where we get a total 3-point contraction of the upper extremity. That's where we're going to get flexion or contraction in the biceps brachii muscles, the muscles that are going to flex the elbow, as well as muscles that will flex the wrist and flex the hand, that lead to distinct signatures of hypocalcemia. Phosphate is an abundant intracellular anion. We have about 500 to 800 grams of phosphate in our body. About 85% of that phosphate is going to be found within the bones in the bone crystal known as hydroxyapatite. In terms of concentration of inorganic phosphate in the blood, we're going to be somewhere between 3.4 and 4.5 milligrams per deciliter, with men being slightly higher than women based off of ATP needs and lean muscle mass or lean body mass. We will see a change in phosphate based off of the need to regulate an ion gap that is part of the buffering system that's going to take place, and the utilization of the phosphates in the buffers, particularly in terms of changes in acidotic conditions due to changes in metabolic conditions. So what are some of the things that are going to cause changes in the phosphates within the body? So what happens if we have too much phosphate? Hyperphosphatemia. Hyperphosphatemia is typically going to be caused by an excessive phosphate load. That excessive phosphate load can come about due to massive tissue breakdown associated with rhabdomyolysis, as well as tumor lysis issues, where we have rapid turnover associated with large amounts of cell damage and cell death. We could see kidney diseases coming into play, leading to changes in phosphate retentions and phosphate excretions, as well as changes in calcitrol, as well as vitamin D production. We could see transcellular shifts that are associated with metabolic acidosis and the need to buffer acids within the body. We could see a hypoparathyroidism or pseudohypoparathyroidism. That is where we have a reduced parathyroid hormone or resistance to parathyroid thyroid hormonism, that is typically associated with changes in calcium levels. Once again, changes in calcium levels will also be seen with changes in phosphate levels, as well as changes in other of the electrolytes, such as magnesium. So what are some of the signs and symptoms we're going to see with hyperphosphatemia? We're going to see muscle cramps and spasms. We're going to see numbness and tingling in and around the mouth, as well as in the hands and the feet, where we have fine sensations taking place. We're going to see changes in bone. Those changes in bone can lead to bone and joint pain, as well as bone and bone weakness, and an increased risk for fractures. We may see rashes and itchiness within the skin that is going to be tied with changes in sensation that we see within the sensory neurons of the skin, particularly in and around the hands and feet. What about hypo conditions, where we have too little of these? This is typically going to be with inadequate intake. This is usually going to occur with poor phosphate dietary sources, malabsorption, or intestinal binding issues. We may see an increased loss of phosphates associated with low vitamin D levels. We may see it with chronic kidney diseases. We may see it with hepatic dysfunctions. We may see it with malabsorption due to diarrhea, as well as a constant consumption of acids containing aluminum, magnesium, and calcium. We may see excessive renal losses due to kidney diseases, as well as mutations in the transporters, along with changes in vitamin D production, as well as calcitrol production. We may see a redistribution issues, an intracellular shifting of phosphates that usually gets seen with refeeding syndrome that is associated with an uncontrolled diabetic condition, where we have prolonged starvation or a diabetic ketoacidotic state, where starvation or diabetic ketoacidotic state that is met with refeeding leads to storage of nutrients that is needed to be replenished, where phosphates are needed in terms of storing carbohydrates, proteins, and lipids within the body. What are some of the issues that we're going to see in terms of a hypophosphatemia? Well, we're going to see reduced bone mineral density and increased risk for fractures. We're going to see muscle weakness and fatigue. We're going to see an altered mental state. We're going to see irritability and confusion. We can see cardiac arrhythmias and reduced ejection pressures, as well as reduced blood pressures that can lead to a reduced total cardiac output, as well as changes in cardiac functions. We may see depressed respiratory functions due to changes in the chemical signals that are going to cause us to breathe. Magnesium. Magnesium is going to be tied with calcium and phosphate in terms of its regulation, which means that if we start seeing changes in calcium and phosphate, we'll typically see changes in magnesium as well. We typically have about 25 grams of magnesium in the body. It's the second most abundant intracellular cation after potassium, and it's a cofactor in many of the biochemical reactions that help us maintain our normal homeostatic functions. These include things like protein synthesis, ATP synthesis, stabilization of the cell membrane, DNA synthesis, bone metabolism, cardiac functions, action potentials in muscle and nerves or the excitable tissues, as well as glucose metabolism and response to insulin. Any changes in magnesium levels can cause changes in all of our normal homeostatic levels. There is a push amongst many social media to have us increase our magnesium intake. The problem is that most of us are not magnesium deficient. We typically get enough magnesium in our diet. And we have to worry about that because if we have too much magnesium, anything above that 2.6 milligrams per deciliter, with our normal range being 1.46 to 2.68, we can have issues. So, what are some of the things we have to worry about in terms of hypermagnesium? Hypermagnesia is typically associated with renal issues associated with hypoparathyroidism and other adrenal issues, as well as excessive intake of laxatives and alkaline milk consumption that is seen with medicines used to treat acid reflux issues. And so what are some of the issues we might see in terms of this hypermagnesia? Hypermagnesia can be asymptomatic. We may get weakness and nausea. We may get dizziness. We may get some confusion. However, as that level of hypermagnesia increases, we can start seeing decreases in reflex behaviors. We can see worsening of states of confusion. We may see some headaches. We may see changes in our ability to have bowel movements leading to constipation. We may see increase in paralysis of muscles and flaccidity of muscles with excessive consumption of magnesium. We may see hypotensive responses within the heart, as well as changes in the ECG. We may see lethargy. We may see loss of focus. We may see cardiac and cardiorespiratory arrest when levels of magnesium exceed 15 milligrams per deciliter. Well, that's what happens if we have too much magnesium. What happens if we have too little magnesium? Hypomagnesia. Hypomagnesia is typically going to come about due to dietary issues, starvation, alcohol issue, anorexia nervosa. We may see it with terminal cancer issues due to starvation or wasting. Medications such as loop diuretics, proton pump inhibitors, as well as medications like digitalis and chemotherapy drugs, as well as laxative abuse. Treatments involved with diabetic ketoacidosis with insulin, refeeding syndrome, or in terms of correction for metabolic acidosis, acute pancreatitis, as well as ethanol withdrawal may cause this issue. Gastrointestinal losses, such as diarrhea or chronic diseases such as Crohn's or ulcerative colitis. Bypass surgery can lead to a hypocondition. There are certain genetic disorders that will inhibit the ability to absorb magnesium or utilize magnesium or change the way in which the kidneys function in terms of the ability to retain magnesium. Other diseases such as Hungry bone syndrome, as well as acute pancreatitis and early onset diabetes mellitus may cause issues with magnesium levels. So what might we see in terms of issues or conditions that are associated with hypomagnesium? These are going to be things that we can break up into either neuromuscular issues, issues within the nervous system, issues within the muscle system, cardiovascular issues, or bone issues. Neuromuscular, we're going to see hyperexcitability and hyperreflexivity. We're going to see resting tremors. We're going to see tetany, which includes flexure tetany. We're going to see muscle spasms. We're going to see muscle cramps. We're going to see possible seizures. We're going to see nystagmus within the eye movements. Cognitively, we may see apathy. We may see delirium. We may see depression. We may see agitation. We may see psychosis. In some excessive conditions, hypomagnesia may actually lead to coma. In terms of cardiovascular issues, we may see changes in electrocardiogram. We may see atrial and ventricular premature systole. We may see fibrillations. We may see ventricular arrhythmias. We could possibly see cardiac ischemia. In terms of bone issues, we may see changes in overall bone health, once again associated with changes in the calcium as well as with the phosphate. Which takes us to potassium. Potassium is the most abundant intercellular cation. The concentration is regulated predominantly through sodium-potassium pump actions within the excitable tissues. Potassium is required for the propagation of action potentials and the establishment of memory potentials in all of the excitable tissues, muscles, nerves. Normal range for potassium is going to be between 3.6 and 5.5 millimoles per liter. What happens if we have too much? Hyperkalemia. Hyperkalemia can either come about due to increased potassium intake, increased potassium release from the cells, or reduced potassium excretion at the kidneys. Increased potassium intake can come about due to overconsumption of high potassium foods such as dried fruits, seaweed, nuts, molasses, avocados, lima beans, spinach, potatoes, tomatoes, broccoli, beets, carrots, squash, kiwis, mangoes, oranges, bananas, and cantaloupe. We may see an increase in potassium release from the cells associated with metabolic acidosis, increased tissue catabolism, use of beta blockers, insulin deficiencies, as well as DKA, diabetic ketoacidosis, associated with hyperglycemia and hyperosmolarity. The hyperosmolarity particularly coming about due to exercise and or drug use, drug or medication use, such as volatile anesthetics. We may see it with blood transfusions. We may see it with cellular injuries from excessive exercise, such as with rhabdomyolysis, or with metabolic acidosis following exercise. We may see it with sepsis and sepsis-related dehydration associated with heat stroke and heat exhaustion. The reduction in potassium excretion coming about at the kidneys is typically associated with aldosterone issues. So what are some of the issues we're going to see in terms of a hyperkalemia? Hyperkalemia can lead to tiredness and weakness. It could lead to a feeling of numbness and tingling within the extremities. It could lead to nausea and vomiting. It could lead to trouble breathing. It may lead to angina, chest pain with palpitations, and irregular heartbeats. We may see changes in neuromuscular functions. We may see changes in reflexivity. We may see changes in sleeping and normal feelings of wellness. What about if we have too little? Hypokalemia. Hypokalemia is typically associated with a decreased potassium intake, an increase in intracellular uptake, or an increase in potassium losses at the kidneys. This comes about due to poor nutrition or following specific dietary restrictions that limits potassium intake or having eating disorders. Increased intracellular uptake can be associated with abnormal insulin injections, as well as the use of beta-adrenergic inhalations or inhalers. Increased potassium losses can occur due to excessive sweating, the use of loop diuretics, renal disorders, excessive diarrhea, and vomiting. So what kinds of issues might come about due to hypokalemia? Well, most of these are going to come about due to a hypocation conditioning throughout the body. This is the most common of the hypocation issues that we're going to see. This includes muscle cramping, tiredness, weakness, constipation, trouble breathing, and arrhythmias. Takes us to the second anion that we're going to look at. That's the chloride ion. Chloride is the negative charge ion. It's predominantly going to be found in the extracellular compartment with potassium. It's going to help maintain the normal membrane functions throughout the body. It's also going to be moving across the membranes associated with potassium and sodium movements. Normal range is between 96 and 106 milliequivalents per liter. Typical changes in chloride are going to be associated with acidosis and alkalotic states, changes in our acids and bases, changes in our overall pH. What happens if we have too much hyperchloremia? Causes of hyperchloremia include excessive saline infusion, severe diarrhea, chronic or acute kidney diseases, ingestion of salt water, extreme high ingestion of dietary salt, bromide poisoning, renal or metabolic acidosis, respiratory alkalosis, long-term use of carbonic anhydrase inhibitors. A lot of times we're going to see changes in chloride associated with changes in pH. This is typically going to be seen with a change in bicarbonate due to the buffering loss that might come about and the change in what's referred to as the anion gap. The anion gap is how we're able to maintain normal pH, and it's usually maintained by bicarbonate and by chloride ions in the bloodstream. As we become acidotic, we're going to start to see a shift in the anion gap. Elevations in chloride may be seen when we start to have reduction in the amount of bicarbonate available for buffering. So what kind of issues are we going to see in terms of a hyperkalemia? Typically, we're not going to see much unless we start seeing other types of electrolyte issues, which means it's going to be asymptomatic without secondary electrolyte issues. A lot of times we might see this with acidosis associated issues such as muscle cramping, weakness, fatigue, bone weakness, kidney stone formations, altered levels of consciousness, and possible heart arrhythmias. What happens if we have too little chloride? Hypochloremia. Hypochloremia can be associated with changes in sodium levels, either hypo or hyponatremia, based on the amount of sodium that we see in the diet related to the amount of fluid being consumed. We're going to see this with overhydration during exercise, excessive alkaline water consumption, genetic disorders such as cystic fibrosis, gastrointestinal diseases that impact chloride absorption, eating disorders and excessive vomiting, metabolic alkalosis, and medications such as laxative, diuretics, corticosteroids, and bicarbonate abuse. We're frequently going to see this accompanied by hyponatremia. However, that's not always the case. However, when we have low salt intake, we will have low chloride levels leading to hypochloremia. So what are some of the issues we're going to see? Once again, typically it's going to be asymptomatic without secondary electrolyte issues, but we will see muscle cramping, weakness and fatigue, edema and swelling within the periphery, possible edema and swelling within the cerebral cortex, within the brain. We may see altered levels of consciousness. We may see heart arrhythmias and changes in ECG, as well as changes in blood pressure. Which takes us to the last of the electrolytes we're going to take a look at with this presentation, looking at sodium. Sodium is the most osmotically active cation in the body. It's essential in terms of maintaining extracellular volume, that is the volume of fluid within the body. Does this through creation of a rather large hydration sphere, that is a sphere of ionic charge. It's going to attract water around it. The concentration differences of sodium across the membrane, along with concentration differences of chloride and potassium, are going to be essential for regulating membrane potentials of the cells. The diffusion of sodium, as well as chloride and potassium, is going to be necessary for the development and propagation of action potentials in excitable tissues such as muscle and nerve. Typical range is between 135 to 145 millimoles per liter. We start looking at changes in sodium levels. We look at it based off of changes in fluid volume, total body water, based off of being hypovolemic, that is going to be a loss of total body water. Euvolemic, that is where we're going to keep normal body water. Or hypervolemic, that's where we're going to add body water. We start looking at what happens if we have too much sodium. This is hypernatremia. Hypernatremia can come about due to hypovolemic changes. That is, we're going to decrease total body water, leading to greater sodium concentrations. This is typically seen with exercise-induced dehydration, diet-induced dehydration, diuretic use, uncontrolled diabetes mellitus, or excessive salt intake without compensatory water intake. We might also see euvolemic hypernatremia. This is where we're going to keep normal total body water concentrations, but it simply increase sodium concentrations. This is seen with excessive salt intake, but normal water intake, diabetes insipidus, medications such as antidepressants, lithium, and as well as consumption of alkaline water in excess. Trauma such as skin burns and severe burns, as well as diseases such as chronic kidney diseases, can lead to hypernatremic issues. What are some of the issues we're going to see in terms of hypernatremia? Once again, this is going to be the most frequently associated issue that we see in terms of exercise-induced changes stemming from hydration. We're going to see things like tachycardia and arrhythmias. We're going to see muscle cramping and tectonic contractures. We will see headaches. We'll see altered levels of consciousness. We'll see tachypnea. So we'll see rapid heart rates. We'll see rapid breathing. We may see irregularities in heart rates. We'll see irregularities in muscle contractions. We'll see irregularities in nerve functions. We may see sleeping difficulties and restlessness. In some conditions, we may see cerebral edema, particularly when we have severe dehydration taking place, severe hypovolemic changes. Sometimes those severe hypovolemic changes, when associated with alcohol intoxication, may lead to an osmotic demyelination syndrome for an individual in some excessively severe cases of hypernatremia. Opposite of hypernatremia is going to be hyponatremia. That is when we have too little sodium that comes about. Once again, just like with the hypernatremia, we look at it in terms of changes in blood volume or total body water. This is where we can have a hypovolemic change, a hypervolemic change, or a euvolemic change. We can see an increase in total body water due to increase in fluid consumption. We may see a change in gastrointestinal fluid loss, diarrhea, and vomiting. We may see pancreatitis. We may see changes in bowel movement. We may see diuretic use cause the hypovolemic, hyponatremic changes. We may see mineralocorticoid deficiencies, aldosterone deficiencies. We may see issues with glucosuria. This is seen with people with uncontrolled diabetes. We may have a hypervolemic hyponatremic condition. This is where we see an increase in total body water leading to a dilution of sodium concentrations. This can come about due to renal failure. This can come about due to nephrotic changes. This can come about due to congestive heart failure, possibly cirrhosis, or from the excessive consumption of fluid without compensatory increase in electrolytes. We may also see it where we see no changes in volume, but simply see a dilution of the body water. This can come about due to excessive ADH release, excessive vasopressin release, Addison's disease, hypothyroidism, excessive fluid consumption, fluid infusion through catheterization, through IV, or through enemas, medications such as vasopressin and oxytocin analogs, SSRIs and antidepressants, opioids, NSAIDs, nicotine, MDMA, and antipsychotics all have the potential for causing hyponatremic issues. So, what are some of the hyponatremic issues that we have to worry about? And once again, this is typically going to be associated with excessive water consumption or water poisoning, water toxicity for people who follow normal lifestyle. Things that we might see include weakness, fatigue or low energy, headaches, nausea, vomiting, muscle cramps and spasms, confusion, irritability, overreactive reflexes, loss of consciousness, seizures, and in some severe cases, comas and even death. Well, that was just some of the electrolytes of importance for the body. Please stay tuned for more talks on the pathophysiology stuff, particularly looking at acid-base issues and further discussion on electrolyte issues. We'll have other discussions about various types of diseases. If you have a specific disease or specific pathology you wish us to talk about, please make sure you leave it in the comments. We're more than happy to discuss it and give you more information about it. Please make sure you're following us on all of the various platforms here on YouTube as well as the podcast. Check out the written stuff in Substack. Follow us on Instagram as well as on Threads.